All right, good morning or good afternoon or good evening, depending on when you're watching this. My name is Dr. Jill Kelderman, and I am a pediatric neuropsychologist, and I am here on behalf of FAU CARD and PEPSA to talk about autism and differentiating autism from different types of eligibilities through the school. Before we start, I want to take a little bit of time to talk about FAU CARD and their mission. FAU CARD provides expert consulting, training, and support at no charge for all people across all races, ethnicities, and gender groups with autism as well as related disabilities. FAU CARD also supports their families, employers, professionals, the community, and government agencies. The vision of FAU CARD is to provide support and assistance with the goal of optimizing the potential of all people across all race, ethnic, and gender groups with autism and related disabilities. FAU CARD serves the counties that you see here, including Indian River, St. Lucie, Martin, Okeechobee, and Palm Beach. And their offices are located in Boca Raton, Jupiter, and Port St. Lucie. And a little bit about me. My name, as I said, is Dr. Jill Kelderman. I am a pediatric neuropsychologist, board certified through the American Board of Professional Psychology. So I have a lot of experience in training and spend my time primarily conducting neuropsychological evaluations of infants, toddlers, and children with a variety of neurodevelopmental disorders. And autism is certainly one of my primary areas of specialty. I'm located at the Center for Pediatric Neuropsychology. Our primary clinic is in Palm Beach Gardens, Florida. And I wanted to take a moment to introduce the rest of my team at the clinic, Dr. Panora and Dr. Bowles, both of whom also have extensive experience working with autism and other disabilities. And Dr. Bowles in particular also works with the 0 to 5 age range, which we will be talking about, while Dr. Panora tends to focus on the later elementary, adolescent, and young adult population. So just to start out with a brief overview about what we're going to talk about in the next hour, we're going to talk about this idea of differentiating between autism, developmental disability and intellectual disability, and emotional behavioral disabilities, and focus on why is it important? Why does it matter? So we'll do a fairly comprehensive overview of autism, and during that time I'm going to kind of try to weave in some specific points and issues that tend to come up and are relevant, and then we'll kind of go over these different designations and diagnostic conceptualizations and talk about the relationship between them. And then towards the end, I picked kind of a classic example of what might happen in a classroom and why it matters when we think about these different designations. And before we do this, I really want to talk about this idea of the difference between a diagnosis versus eligibility. So within the school, our school-based teams, our IEP teams, our educators refer students and determine eligibility for services based on criteria that's outlined through the school district. And it's important because it provides a framework for the educational supports and strategies that will be used with that student, different types of therapies, language therapy, OT, speech, things along that line, as well as accommodations and modifications that they may be eligible for. So that's from the school perspective. From the clinical perspective, a specialist will determine a medical diagnosis that's based on the DSM-5 diagnostic criteria. And we do that in order to identify and provide families and other clinicians with a framework for the treatment plan, as well as what type of therapies, specific therapies will be helpful for this individual. And oftentimes we're also talking about psychopharmacological support for the child. So what types of medications might be helpful? Are there medications that might be helpful? And what is the likelihood that there's a medication that might be helpful? The DSM diagnosis also provides, in the process of obtaining the DSM diagnosis, will provide a family specific information regarding the etiology for their child's behavior. And we'll be talking about that quite a bit. Why do they do that? Where does the behavior come from? A classic behaviorist may say it does not matter and it's not relevant. We're going to target the behavior. That's another lecture. But for our purposes today, we're really going to think about understanding the etiology of a child or a student's behavior and how that will impact how we respond to that behavior and what types of supports we put into place. When we do our evaluations, we also provide families with expectations for short-term functioning, for long-term functioning. If we're talking about intellectual disability, we're talking about autism. Parents often have very legitimate and understandable questions about, where are we going to be when they're 21? Where are we going to be when they're 30? And for some families, that requires really specific long-term planning because there's limitations in terms of the long-term level of independence. We also will provide specific referrals to providers and resources in the community. If there's other avenues of treatment, if there's a specific type of therapy, we'll have that conversation with parents, and we may provide them specific names of people who we know have particular expertise or who tend to do really well with students who have a certain profile or a certain type of challenge. We also provide documentation for insurance, which is sometimes needed, particularly when we're talking about ABA or applied behavior analysis to treat autism. So many parents are not aware of this distinction. They don't understand, to no fault of their own, that a designation on an IEP is not the same as a medical diagnosis. So we may have a family come in whose 5-year-old has had services through the school, who may have a DD or a developmental delay eligibility on their IEP, but they may think that means the child does not have autism, or they do not have a learning disability or something to that effect. So sometimes we have the conversation with parents about, and we're going to talk further about this, the schools have one system to determine eligibility, and in terms of the medical or clinical evaluation, we're looking kind of a very similar, but different set of criteria. This is relevant because sometimes we have children who come in who, from our clinical opinion, meet criteria for a DSM diagnosis, but the family may not, or the family may not be aware of it, or the child may not have qualified for services through the school. We see this especially with younger girls, elementary age girls who have autism, kind of what we used to call Asperger's profile. And they may be really good at compensating. They may do very well at imitating their peers and behaving appropriately in the classroom, but there are sometimes subtle problems that are there that are starting to become increasingly problematic. And oftentimes students with this profile may have particular difficulty at home. They kind of get through the school day and then have significant issues at home. So it's, this designation, again, can sometimes be an important conversation to have with families. But as we talk about these things today, we're going to kind of flip between the DSM criteria and school eligibility criteria. So in brief, there's a lot of information on these slides. I'm not going to go through them in detail, but in brief, I wanted to give an overview of autism criteria. So there's two main categories that we look at. The kind of fundamental deficit of autism is with social communication and social reciprocity. Reciprocity meaning that back and forth. So individuals with autism may have or do have decreased social emotional reciprocity. They might not be as responsive or as tuned into other people in their environment. They have difficulty with nonverbal communication. The classic example is eye contact, but this goes well beyond eye contact to include gestures, prosody, which is the inflection and tone of voice when you're speaking, facial expressions, how animated someone is. And it's not just the child's use of nonverbal communication. This also pertains to their ability to understand other people's nonverbal communication. And then we also look at the child's ability to develop and maintain relationships and to understand relationships. So again, it's not, do I have friends or not? It's, can they develop friendships? Can they maintain meaningful friendships over time at a developmentally appropriate level? And do they really understand their role within a relationship as well as other people's roles? The second category has to do with restricted and repetitive behaviors and interests. So we look at repetitive motor movements. Again, the classic is a hand flapping, but we also look at repetitive language. Some children with autism tend to use the same phrases with very high frequency, or kind of use the same patterns of speech. Repetitive behaviors can include classic things such as lining things up. You know, the hand flapping is kind of the classic example we tend to see, but it can also include other motor movements such as tensing behavior. We oftentimes see kids who present with significant features of rigidity. So this is the way it needs to be. This is the way it's going to go. That insistence on sameness. So they may have very clear patterns of behavior or routines that they insist on at home or at places in the community. It does not mean that these patterns of behavior, that these routines cannot be adjusted, but it can definitely be hard for that to happen, particularly without the right type of treatment in place. Within autism, we often see really intense interests. So people are really interested in, you know, dinosaurs, trains, Pokemon, anime. There's kind of a category of certain things that tend to be particularly interesting to young students with autism. And then we also see sensory differences. So either children can be very, show really aversive reactions to certain types of sensory input. So certain sounds may trigger a meltdown, or they may be very sensory seeking and, for example, tend to sniff things, or like to rub things on their cheek, or kind of constantly be touching things and really seeming to focus on how it feels. Some additional notes, ASD is neurodevelopmental, meaning that the child is essentially born with it and the manifestation of that evolves over time. For people who have relatively mild forms of autism, their symptoms might not be particularly prominent early on, but they are there. They may, as children grow older, they tend to grow into the difficulties and deficits because the gap widens between they and their peers. The symptoms have to cause a problem. If it's not a problem, it's not a problem. So as is true for most DSM diagnostic conceptualizations, the symptoms have to cause significant impairment in certain areas of functioning. And from a DSM perspective, the symptoms of ASD cannot be really attributable to intellectual disability or global delay. And we're going to talk about that precise issue at length. Intellectual disability and autism often co-occur. Different studies will show different percentages, but it's probably around not quite 50% of individuals with autism may have intellectual disability. As we have become more proficient at identifying or individuals who have relatively mild symptoms of autism, that percentage has decreased because we've kind of identifying individuals who may in fact have extremely strong intellectual abilities, but yet have social communication weaknesses. These are, I'm not going to go over these in details for the sake of time right now, but these are kind of some of the more specific examples of each diagnostic criteria, I think the main point to think about is for all of these criteria, the idea isn't that this ability isn't there. Certainly for people who have more severe forms of autism, they may truly lack some of these skills. However, for most kids with autism, it's a matter of how weak is it. So it may not be there with expected frequency, or it may not have the quality that we look for. So some students with autism, for example, may initiate constantly. So they may say, did you know this? Have I told you about this? Have you ever seen this movie? And they're constantly initiating and starting a social interaction. But if it's the same 6 comments they're using, if it's the same 6 topics they're introducing, that's not really the breadth that we would expect to see. So there is a difference there. And when we think about nonverbal communication, I've had many parents say, I was told they don't have autism because their eye contact's good. Well, the diagnostic criteria isn't eye contact, it's nonverbal communication. And if you look at the specific verbiage, it says ranging, for example. So there's a broad range of behaviors within each of these criteria. And within that, then we're also going to look at specifiers such as frequency and the quality of them. Just students with autism often enjoy playing with other kids. It's not that they have to have no interest in other children. I've heard comments such as, he can't have autism, he loves to play football at recess with the other kids. That's not a rule out. That's definitely a positive and something to work with, but it's much more complex and sophisticated analysis than a yes, no, this happens or not. Okay, so we're going to move on to talk briefly about early diagnosis, which is kind of a topic that's near and dear to my heart because it's so very important, and I'm going to take a few minutes to tell you why. And again, I'm talking about early diagnosis for autism. So we hear parents say, a lot of parents come in with similar stories, and they may say, I knew at 6 months something was different. I knew by their first birthday there was something that was a little off, but I didn't know what it was. Oftentimes what happens is parents, their concerns aren't validated. They're not validated by physicians. They may not be validated by family members. They may have grandparents who say, he's fine, don't worry about it. Boys talk later than girls. Well, not significantly. We don't have different norms for language development based on sex. So that's not really a valid point. He's letting his sister talk for him. We'll check back in 6 months. They'll be talking then. These are all the types of things that we hear with very high frequency. I think my biggest concern is this wait and see attitude or approach, because as I'm going to illustrate in a moment, it's very important to identify children at a very young age, meaning 1 or 2. We don't look at a brain MRI that's suspicious for a tumor and say, well, let's check back in 6 months, right? We need to determine what the issue is so that we can be proactive and address the issue as soon as possible. And that same conceptualization applies when we think about autism. It may be hard for pediatricians to take the time that it sometimes takes to see some of the difficulties that young children with autism have. Early educators may have concerns and may see behaviors in school that parents might not see at home, but they may not always have the ability to be frank with families and say, this is what I see, or they may be really concerned, what if I'm wrong? I don't want to upset the parents. And I think that fear of scaring the parents is quite common. But if your child has autism, you should be concerned. It's a very important issue. So understandably, we don't want to cause anxiety and scare parents without good cause. But erring on the side of caution, knowing what we know about early diagnosis is important. And then I would also add that we often hear parents say, we were told we can't get a diagnosis until 3. We were told he's too young for an evaluation. We can evaluate children as young as they come. We can do developmental measures. We can look at adaptive functioning. We can interview the parents. We can do the ADOS toddler module, the ADOS being a diagnostic tool that's very helpful as soon as the child can walk. So again, it's not that they're only 18 months. We can't look at this. We can and we should. And why does it matter? It matters because early intervention in autism is incredibly important, and we know that it alters developmental trajectory over the long term. And there are critical periods of development in early childhood, meaning prior to the age of 5, where essentially we get the most bang for our buck in terms of therapy. And once that time frame has passed, we can't really go back and have that same level of efficacy. It doesn't mean that therapy isn't helpful after the age of 5. That's not at all true. But we know it's very critical to have it at an early age. And in this study, for example, looked at a group of kids who are often called optimal outcome, or OO. And these are kids who have an early diagnosis of autism. They have intervention, and by the time they're in elementary school, they don't meet DSM-5 diagnostic criteria for autism any longer. This is a minority of kids with autism. It may be not quite 20%, but it is certainly a group that we know exists. So the question is, obviously, who's in this group and what's different about them? And the research is increasingly telling us what's different about this group is that they're getting services at a very young age. So if you look at this graph just briefly, the optimal outcome group, you can see by the gray line on top, the percentage of kids in the optimal outcome group who had ABA therapy by the age of 5 versus the percentage of kids who were in the high functioning autism group at the age of 5 is significantly different. And just to give you some specifics, so 40% of kids who were in an optimal outcome group in early elementary had ABA beginning at the ages of between 2 to 2.5, so 40%. 4% of the high functioning group had ABA in place at that early age. So it's really important, and there's much more to talk about, but for the sake of time, I hope the takeaway is it's very important for kids with autism to have early intervention and to be identified and receive the proper treatments, because it can really alter their developmental trajectory, and it impacts the rest of their life, and it impacts their families' lives as well. All right, so moving on to some of these related but distinct diagnoses or eligibility criteria. So talking about developmental delay. So this is a fairly broad term. The corresponding DSM diagnosis, global developmental delay, is often used as well. So, but really we're thinking about the 5 and under age group, and these may be children whose severity of intellectual impairment can't be reliably assessed. So they may not be able to participate in the test process. They may belong to a group such as autism, where we know there could be some significant fluctuations in their level of intellectual functioning over time. But we know that, or what we see is that kids are not meeting their milestones in several areas. So it may be language and gross motor skills and fine motor skills. It may include adaptive functioning. It may include visual, spatial, or nonverbal processing. And from the educational perspective, after early steps, which usually covers 0 to 2 through 2, the IEP designation is going to to be relevant for kids who are 3 to 5 years old. And what we see clinically is a lot of children who have autism or who eventually have an autism diagnosis have a designation of developmental delay for this 3 to 5 age range. That can be a very confusing issue for parents as well. And again, what we'll hear is, well, the school said they don't have autism, when in actuality, the school probably meant or implied or said, this is the designation that we're going to use right now because that's how it's written. Global developmental delay, typically, not always, but typically is going to develop into intellectual disability. The idea is that if we identify children at a very young age and put evidence-based supports into place, that hopefully we can optimize functioning long term. But moving into intellectual disability, so again, these are the DSM-5 criteria, abbreviated. So we have intellectual and adaptive functioning deficits in conceptual, social, and practical domains. So the deficits in intelligence includes areas including reasoning, problem solving, planning, but it includes, there's a pretty lengthy list of what it includes in DSM. And it needs to be confirmed through an assessment and standardized IQ testing. Intellectual disability also includes deficits in adaptive functioning. So adaptive functioning includes how well an individual can effectively engage in these day-to-day behaviors that help us function in the community and in our homes. So it includes being able to navigate your community and to make purchases in stores, to use public transportation, managing money, as well as social skills, social functioning, maintaining relationships, functional communication. These all fall under this category of adaptive functioning. Similar to autism, intellectual disability is neurodevelopmental in nature, meaning that the child is essentially born from it and the manifestation emerges as the child grows and develops and matures. And we have different specifiers for intellectual disability, mild, moderate, severe, and profound. From an educational perspective, most of the students that we're going to see and work with will have mild intellectual disability, and generally speaking, that's the largest group among intellectual disability. Most individuals are in that mild range. Broadly speaking, very roughly speaking, an individual with mild intellectual disability is going to, as an adult, function at a late elementary level of academic skills and kind of comparable levels, again, very roughly speaking, problem-solving abilities and so forth. Intellectual disability implies a slower learning rate. So children need more presentations of information. Instead of presenting the information 3 times, we may have to present it 20 times. We may be more prone to lose information that we have learned. So it may seem that it's there, and then we come back a few weeks later and it's not there anymore. This is because of the, again, slower learning rate, weaknesses in retention or hanging on to information. And when we think about intellectual disability, there's not really an expectation that we're going to catch up, right? If we have a child who, for example, has an isolated language disorder, so they have, generally average intellectual abilities, for example, but they had a language delay and for whatever reason did not receive early language therapy, and now we see kind of a language-based weakness. There is a very real expectation that if we put the proper supports in place, they're going to catch up, if not entirely, to a significant degree. That's not necessarily the case in intellectual disability. We're really thinking about optimizing potential and helping the child achieve to their personal best, with the understanding that their personal best is going to be lower than that of most of their peers from a cognitive perspective. And then a note on intellectual disability and autism. These are two conditions which are highly comorbid. As I mentioned earlier, close to half of, again, depends on the study and how we're defining things, but almost half of individuals with autism will also have intellectual disability. So ABA, or applied behavior analysis, is an effective treatment for intellectual disability. It's an effective treatment for autism. ABA is considered to be the most effective treatment for autism. But again, it works for everybody. It works for children who don't have a neurodevelopmental disorder. ABA is based on basic operant conditioning principles that reinforce desirable behaviors and extinguish or decrease the likelihood of problematic behaviors. So it's relevant, though, because IQ is the biggest predictor of long-term functioning in autism. If we want to look at the likelihood that an 8-year-old with autism will be able to function independently as an adult and independently maintain a job or go to a trade school or undergrad, for example, the biggest predictor that we're going to look at is their level of intellectual functioning. We know that intensive early behavioral interventions, such as ABA, has the potential to improve IQ in autism for a variety of reasons, and it's probably, the mechanism is almost certainly multifaceted, but ABA can improve IQ in autism. IQ is the biggest predictor of long-term functioning, so it's really important, again, to effectively identify these children and put the proper educational supports and therapeutic supports in place in order to optimize their neurocognitive potential. So how do we effectively differentiate? How do we decide or determine if a child has developmental delay or intellectual disability versus autism? And this can be tricky, but some of the key things to think about is that if, when we look at social and emotional reciprocity, typically, for example, if you have a 2-year-old who's typically developing, you are usually going to be bombarded by social overtures constantly. Look, they're going to be showing you things, sharing you things, pulling you into their world, talking, imitating what you say, laughing, smiling, and very much interacting. And if someone has an emotional reaction, if they drop something on their foot and they're in pain, a 2-year-old, just as an illustration, they're going to pause. They're going to respond to that emotional tone. That's that emotional reciprocity. So when we look at social emotional reciprocity, when we think about intellectual disability versus autism, the general idea is that in a child with intellectual disability, the social and emotional reciprocity is generally intact, but it's more likely to be immature. So you may have, for example, if you have a 9-year-old who intellectually and cognitively is functioning at a 5 or 6-year-old level, you would expect to see that social and emotional reciprocity at approximately the same level. That doesn't mean it's going to look exactly like a 5-year-old in terms of their social overtures and their play skills, but you should see some nice abilities that are there. In contrast, when we think about autism, the social and emotional reciprocity is absent or nearly absent, or it's very atypical and it's unusual. It doesn't have that same quality, excuse me, as we might expect to see. So you may have a 9-year-old, for example, with autism, and they may not initiate or very rarely initiate, or they may initiate and persist about their preferred topics of conversation or their preferred interests, but not kind of have that bounce in terms of, what do you think about it? Or do you like that? Or have you ever gone there? One issue that can be really tricky sometimes is when we look at restricted and repetitive behaviors. So within the intellectual disability population, the lower the IQ, the more likely we're going to see repetitive behaviors, such as rocking back and forth, hand flapping, some sensory aversions. Again, the lower the IQ, the more likely we're going to see those types of behaviors. So they may be there. In autism, they're present by definition. We're going to see them. If they're not there, it's not autism. So it's a piece of the puzzle that we really have to take into consideration with multiple other data points to think about, where is this behavior coming from? When we look at neurocognitive profiles, again, generally speaking as a group, students who have intellectual disability are probably more likely to have a flat profile, meaning that most of their neurocognitive abilities are going to fall within the same range, kind of possibly if we think about standardized scores, for example, most of their abilities are in the 60s, right around the first percentile. In autism, we're much more likely to see a very scattered skill profile. So many students with autism, with or without intellectual disability, will have what we call splinter skills. So they may have exceptionally advanced construction-like skills, right? Visual spatial skills. They may be excellent builders or do really well at other types of nonverbal processing, but otherwise have significant weaknesses. So we're more likely to see that type of a profile in autism. Again, these are not blanket all or none statements. These are generalizations. And then whenever we think about autism, we have to think about your gut feeling, your what it feels like to be with the child. So toddlers and young children with intellectual disability usually feel pretty typical, just immature, right? So just younger. And their behavior, if you kind of think about, if I don't look at the physical size of the child, and for example, if we think about our 9-year-old who's at a, what did we say, 5 or 6-year-old level, if we kind of think of that child at a 5 or 6-year-old body, does it all make sense? And if the answer is yes, then that is means we're closer in this intellectual disability area. If we have a 5-year-old, for example, who has major temper tantrums, but then we realize that developmentally they're at about a 36-month age equivalent, cognitively, those temper tantrums are developmentally appropriate. That's what we will look at. Then it all kind of fits in, and maybe these aren't temper tantrums that are more of an autism meltdown. Maybe they're developmentally appropriate. That's what children at that developmental level do. Toddlers with autism are more likely to feel difficult to interact with socially, given that reduced social reciprocity. So it may be really challenging to pull them in and to get them to interact with you or to engage in a non-preferred activity. There's definitely an important aspect of what it feels like. So why is this important? Why is it important from an educational perspective to designate between these different categories? Well, under IDEA, right, students with disabilities have access to a free and appropriate education. And appropriate, it really includes using the right types of strategies, environmental supports, and the least restrictive placements where we can adequately support this child's ability to access the curriculum. So understanding where the behaviors come, where the deficits come from, and what works for children with similar profiles is very relevant. Additionally, things to think about are students who have mild intellectual disability, particularly students who may have some verbal strengths, for example, but many of their other abilities are around the first percentile. They're more likely to perceive the differences between themselves and their peers. And that's an important consideration when we think about placement and emotional and psychological health of the student. If they are a child who is increasingly aware that they cannot read as well as their classmates, or that other students are able to do X, Y, and Z better than they are, and if they're internalizing that, that's a significant concern, and we need to think about that and target it. Designation is important because students with autism are typically going to require more substantial support with specific areas, including social skills and pragmatic language. And the way that we're going to do that is going to incorporate strong behavior modification strategies. Designation is important when we think about reasonable expectations. Children who have lower levels of intellectual functioning don't have the ability to achieve at kind of their standard level to varying degrees. And by understanding their neurocognitive profile, then we can have reasonable expectations and really work to promote their personal best while maintaining their quality of life and their happiness. So understanding what's a reasonable expectation for not only academic achievement, but also behavior is important. And for autism in particular, there is oftentimes a unique neurocognitive profile where we really need to support specific abilities, such as making inferences, theory of mind, which refers to the ability to put yourself in someone else's shoes and easily and effortlessly understand, what somebody might be thinking and or feeling. Okay, so let's talk about emotional behavior disability, or EBD. So EBD is not necessarily a DSM diagnostic entity, but we are going to briefly mention what DSM diagnoses might overlap or be associated with an EBD educational designation. So according to Palm Beach County School District, EBD is defined, and this is an abbreviated version, is a student with an emotional behavior disability has persistence, meaning that they're not responding, RTI, they're not responding to evidence-based interventions, and consistent emotional and behavioral responses that adversely affect performance in the educational environment, and that it's not attributable to age, culture, gender, or ethnicity. So the conversation that we'll have with parents sometimes on our end is, yes, these issues are there, but if they're still doing well academically, if the child is still earning good grades despite the fact they have raging anxiety, that makes it, that's going to affect eligibility determinations. The EBD definition also includes an inability to maintain adequate performance in the educational environment, which again speaks to that. Internal and external factors are outlined on the EBD definition. So internal factors, this essentially overlaps with depression, right? Feelings of sadness, frequent crying, restlessness, loss of interest in friends or schoolwork, mood swings, erratic behaviors. And then we kind of have an anxiety category, fears, phobias, excessive worrying and anxiety. And it can be about school problems, but it can also be about personal problems. And it can result in behaviors that come from these thoughts and feelings that are inconsistent with events. So a misinterpretation of a situation that is secondary to a depressive or negative pessimistic thought pattern, for example. External factors include an inability to build or maintain interpersonal relationships with peers, teachers, other adults in the school setting. So maybe the child is, has severe social anxiety, and this is preventing them from developing friendships. You can have a student with selective mutism whose anxiety is sufficiently severe. They simply do not talk to certain people in their environment. They may talk to teachers, but not talk to classmates or vice versa. External factors also include disruptive behaviors. So behaviors that are chronic and disruptive, such as noncompliance, verbal or physical aggression, poor social skills, but it kind of delineates as this is resulting from the emotional symptoms. and thinking about, excuse me, what DSM diagnostic entities are relevant here. So, there's numerous depression diagnoses, major depressive episode, mood disorders, anxiety. Again, this can be generalized anxiety disorder, social phobia, obsessive compulsive disorder. It could include ADHD, which I'm not spending a lot of time on ADHD. That's probably a whole nother talk. But we often see children with ADHD under an OHI designation, other health impaired, which, well, we'll just leave it at that. So, and then I wanted to comment on ODD, oppositional defiant disorder. So ODD is a diagnostic conceptualization, essentially says that the kid's not doing what we're asking them to do. The question is, that I have is why? Kids aren't innately bad, right? Kids aren't innately lazy. Kids aren't innately oppositional, right? They may be innately stubborn. They may be innately rigid. They may have an innate difficulty with initiation. But these are neurodevelopmental issues that are causing the behaviors. The diagnosis of ODD kind of says it's a bad kid, and it doesn't tell us anything about where the behavior is coming from, why the behavior is there, what we need to do about it. So in the vast majority of cases, it's my professional opinion that the ODD diagnosis, while it is appropriate in some situations, is oftentimes not particularly helpful, and we can better explain the child's challenges through other conceptualizations. Thinking specifically about EBD versus ASD, designation is really important. We have had numerous children. These tend to be older students when you're getting more into middle school and high school who may have relatively mild forms of autism, who maybe have never really been diagnosed. And they have engaged in inappropriate behaviors, they've been disruptive, they've made incredibly inappropriate comments to educators or to peers, and they are ultimately identified as EBD. And they may be placed in an educational setting that's designed to support students with EBD. And that's typically not helpful for students with autism. And at times it may be detrimental and make the problems worse for a variety of reasons. But it is really important to accurately identify where the behavior comes from. And so here's an example. We have a code coming up in a few minutes I will be giving you. So pardon me as I check the timer. So just to give an example, this is a real example. This is a specific one. I've heard these types of stories many, many times. And as educators, you've probably been in the story many, many times. So I had a third, fourth grader who had an assignment. It was a writing assignment in creative writing to pretend you're an alien from another planet and you arrive on Earth. Describe your reaction to this new planet, and it was something to the effect of talk about how you're going to develop relationships with Earthlings. The child went into a shutdown, right? Sat at the table, put his head down, and didn't respond. Refused to pick up the pencil, refused to do anything. Teacher comes over, encourages them to give it a try, walks away, child continues to shut down. Teacher comes back again, a little more urgency in the tone of voice, and then the child sits up, starts to cry, crumples up the paper, throws it at the teacher. Probably made an inappropriate comment while doing so. So the teacher reprimands the students, you can't do that, so on and so forth, probably gives a consequence of some degree. What are the other kids in the class doing? Well, they're probably staring at the kid. They're probably laughing, rolling their eyes. Here they go again. It's probably not the first time something like this has happened. So the kiddo throws the desk over, runs out of the classroom, goes into the bathroom, locks themselves in the stall, crying hysterically and refuses to come out. And then administration becomes involved, parents get called in, et cetera, et cetera. So these types of stories occur fairly regularly. And so let's think about it. Where does the behavior come from, right? What is the etiology for the behavior? If we come at it from an autism angle, right? This task is a horrible task to ask a student with autism to do. It's inherently dependent on theory of mind. You have to be able to put yourself in the perspective of someone who's never been to Earth before. That requires a lot of kind of abstract thinking, imagination. How are we going to develop relationships with Earthlings? So again, we're really tapping into the areas that tend to be the biggest deficits for students with autism. So understanding relationships, being able to verbalize and in a sequential manner how you might make a friend or try to start a relationship. Making inferences is oftentimes one of the biggest weaknesses for students with autism, particularly those who are relatively mild and quite intelligent. That can be this one kind of key area where they have difficulty. But making inferences about how people might respond to that overture. And then above and beyond the content of the assignment, handwriting or visual motor integration is often extremely challenging for students with autism. Motor planning or motor sequencing is one of the most common areas of weakness. So they can often show an aversive response just to the act of writing. Being able to write to the reader, right? Many students with autism have difficulty relaying non-routine events. Tell me about your vacation. What did you do with your family this weekend? To provide the relevant information, you have to understand what the listener does and does not know, and fill in the gaps accordingly. So that in and of itself is also challenging for students with autism. And so they're going to feel very overwhelmed and have this task that is well outside their bounds of competency. So, so then what can we do? Well, an appropriate behavior would probably be to talk to your teacher, verbalize your feelings, ask for help, and calmly say, this is really hard, I don't know how to do this. But again, those all rely on skills, a skill set that most younger students with autism are not going to be well developed in that area. So we can kind of think about these things and all of them occurring together as contributing to that initial shutdown and then eventual response. Okay, so we are at the 50-minute mark. And I want to give you your code. So to obtain the certificate of completion, you must fill out the form at the certificate of completion link provided on the email for the training. So please write down the code as it's required to receive the certificate. The code is DJK, so as in Dr. Jill Kelderman, DJK 100220. Again, the code is DJK 100220. All right. So back to our talk, and we've got maybe 10 minutes left, if you're wondering. So we cover the conceptualization from why that behavior might come from a student with autism. Why might that happen in a student who has intellectual disability? Well, that type of test may just be too hard for them. It may be beyond their intellectual level. So they may not really understand it. They may lack the language to complete the task. They may lack the writing ability, the writing skills. So essentially it's just too hard and they become overwhelmed. And then their resultant behavior is really a manifestation of emotional and behavioral immaturity. So, if a kindergartner became upset with an assignment and put their head down on the table and then ran out of the room, that'd be concerning. That's not an appropriate behavior. But when we see that same behavior in a third or fourth grader, it's a bit more concerning because we should be well past that point developmentally, but it's really a factor of maturity. And then when we think about kind of an emotional and EBD perspective, so let's assume we have a student with significant anxiety or depression. The student who's depressed may look at this and think, I can't do this, it's a waste of my time, I'm going to get an F anyway, and right, that thought process might trigger that type of behavior. They may feel completely overwhelmed, I can't do it, it's too hard, I don't know where to start, right? When we have our students with ADHD and executive dysfunction, initiation and planning are typically weaknesses. So if we give them a large assignment at once, they may have difficulty identifying an appropriate start point and then moving forward through the sequences. And if it just seems like this great big task instead of, well, I'm going to do A, B, C, and D, and then I'll be done, the children and adults can be very overwhelmed, and that's why breaking things down into small steps can often be beneficial. Students with anxiety may be very perfectionistic or have a fear of failure. So if I can't do it perfectly, I'm not going to do it at all. And then students who have more just genuine emotional and behavioral dysregulation may have kind of that inappropriate response. So this is an example, again, of how thinking about where the behavior comes from, when we think about where the behavior comes from, then that in turn will help guide what are we going to do about it, right? How do we support this student? If we take the perspective the behavior is related to, this is a manifestation of the children's cognitive profile secondary to autism. The first thing we're going to do in this particular example is we're going to modify the task demands. Asking a child with significant deficits in theory of mind to put themselves in someone else's shoes and kind of have this elaborate writing response is comparable to asking a child with an orthopedic or a cerebral palsy motor impairment to do something better in gym class or to run faster. It's harder for them because of their neurodevelopmental deficits. So it's not a matter of try harder or do it better or just keep trying. We really need to accommodate, modify, and provide explicit instruction. So in our example, in autism, this might look like a modification of task demands. Okay? We're not going to ask them to do this incredibly abstract, creative writing piece. Let's think of a different type of assignment. So let's pretend, you've never seen Earth before. Maybe you are an alien, but that includes this explicit part of you've never seen Earth before. Describe what you see. Let's talk about more kind of factual information. Talk about forests, the rainforests and deserts and things that are concrete, right? We can modify it that way and kind of address that particular deficit. But meanwhile, we're also going to provide really explicit instruction and support with theory of mind and social thinking in order to foster the development of this ability. It's not that we write it off and say, well, they can't do it, so we're not going to worry about it. We're going to, again, change the load, the academic load and demands, while providing them support with the actual skills that they lack. Similarly, we'll provide explicit instruction, written language, and also spoken language via language therapy and pragmatic therapy, teaching them how to do these things that don't come naturally and are generally harder. We can also provide accommodations such as keyboarding, which will also often decreases that demand and the cognitive load that's associated with just simple handwriting. With an intellectual disability paradigm, we're going to reduce the complexity and the level of the task, and essentially this is access points, right? We're going to change the complexity and the level of abstract thinking required really across all curriculum and modify it so that it's attainable for students who have intellectual disability. And then, of course, we're going to support them through outlets such as small group instruction, language therapy, OT, and so forth. And then from an EBD perspective, we really need to get to the crux of the matter, which is the underlying anxiety and or depression, whatever it may be. So for therapy, we're going to think about cognitive behavioral supports and other different types of psychotherapy that is validated to support and improve symptoms of depression, symptoms of anxiety. We really want to work on improving self-esteem, self-efficacy. If it's an anxiety perfectionism challenge, then we really need to reduce the anxiety and provide exposure therapy, and have them work with a counselor or a therapist who might get to a point where we're going to turn in something wrong on purpose. And we're going to get a B on purpose, and the world's still going to keep spinning, and it's all going to be okay. So there's well-validated therapeutic approaches for these different things. We're going to teach coping skills, right? What do we do when we feel completely overwhelmed? What do we do if we feel a panic attack coming on in the classroom? Again, we have validated interventions for these types of conditions. Family supports is really a key across all these areas, but especially, I think, for the emotional and behavioral kids, because there are some things that are incredibly effective that parents can provide that schools, for whatever reason, cannot provide at the same level. So just to make a note of the family role. I often explain to parents, when we talk about IDEA, when we talk about IEPs, we talk about free and appropriate education. Appropriate is not optimal, right? It doesn't mean that everybody is entitled to the Cadillac of IEPs. It's really what's appropriate and what do we need in order for the child to access the curriculum. The families have responsibilities too. If their child has certain needs, and the proper treatments, the most effective treatments may be medication. It may be intensive individual psychotherapy, working with a psychologist or a therapist who has expertise in a very specific type of therapy, such as habit reversal training. Family therapy may be an important component, right? If there's significant levels of stress or, marital problems in the home, and the child who's depressed is really mirroring and taking on some of their parents' challenges, the intervention needs to include the family as a whole. And those types of things aren't necessarily able to be delivered through an IEP or through the school. So it's important for families to be able to identify and implement those treatment plans. And some families are very capable and effective at doing so, and it's a challenge for other families to do so for a variety of reasons. I think educators often, I imagine, find themselves in a very challenging situation because they may have ideas based on their experience and experience on what might be helpful for a certain student, but if it falls outside of the umbrella of the school, there's limitations on what can be said to families. And I think this must often result in a pretty significant ethical conflict for teachers and for therapists at times. So in a nutshell, so that I hope has given you a decent overview of some of the issues when we think about differentiating autism between different disorders, and why is it important, which I think is a key component. And we will be scheduling, I believe, in the not too distant future, a live presentation that's going to be more of a Q&A that's related to this topic. So if this is helpful, or if you have additional questions, please jot them down now while they're fresh in your mind. And then you should be receiving information about that Q&A in the not too distant future. So thank you.